It is afternoon now, everyone, so we are going to get started. I hope everyone's doing well, and I would like to welcome you and thank you for tuning in today to our webinar on lung cancer screening. Our experts today are going to discuss the new lung cancer screening guidelines, the importance of getting screened, and also talk to you about the NYU Langone Lung Cancer Screening Program and the Lung Module Review Board. So with that being said, I would like to turn the program over to our speakers today, Dr. Daniel Sterman and Dr. Jorge Mercado, who are going to give you more information.
Thank you so much, and good afternoon, everybody, and welcome to today's session on lung cancer screening and expanded recommendations. My name is Dan Sterman, and I am the Division Director for Pulmonary Critical Care and Sleep Medicine at NYU Langone Medical Center, and also the Medical Director of the Lung Cancer Screening Program for NYU on the Manhattan and Brooklyn and associated campuses. Dr. Mercado, are you there? Okay. Well, Dr. Mercado, who is my co-host for the day, is the Associate Division Director in our NYU Langone Brooklyn section. And an expert on diagnostic bronchoscopy for lung cancer. For our agenda today, we are going to do the introductions that we've just done for myself and Dr. Mercado. We're going to be discussing the burden of lung cancer. We're going to be discussing lung cancer screening, how this developed as an area of interest and importance, and then touch upon the updated lung cancer screening recommendations, which are literally hot off the press in the last few weeks. We'll talk about how the Perlmutter Cancer Center lung cancer screening program functions and is structured, as well as the Nodule Review Board, and then we'll have some time at the end of our session today for any questions that you might have. And I think these questions you'll be able to send in through the chat, and you may also be able to raise your hand and say them out loud. I'm not sure how exactly that might work, Rachel. Just in terms of introductions to key members of the NYU Lung Cancer Screening Program, as I mentioned, I'm Dan Sterman, and I am the director of the NYU program based in Manhattan. Dr. Mercado is our associate section chief in Brooklyn, and he is leading our efforts from the physician side in our Brooklyn-based lung cancer screening program. He works together with Jose Lara. Jose is a nurse practitioner who has been working at NYU sites in Brooklyn for the last several years and was recently hired to be the nurse practitioner lead for our NYU lung cancer screening program in Brooklyn and Queens. In Long Island, we have Dr. Jeffrey Schneider, who is a thoracic medical oncologist and the head of our Long Island Cancer Center, who also leads from the physician side our lung cancer screening program in Long Island, and he works very closely with Elisa Braithwaite, who is a nurse, who is the heart and soul of the Long Island program and helps run that program and keep it running on a daily basis. Next slide. And the lung cancer screening program is part of a comprehensive lung cancer center that comprises multiple medical specialties and multiple departments throughout NYU, including the NYU Grossman School of Medicine and the NYU School of Global Public Health. I've introduced you to myself. I'm an interventional pulmonologist. Dr. Schneider, who's a medical oncologist and director of our cancer center in Long Island, but it also comprises Dr. Harvey Pass, who's head of our thoracic surgery research and thoracic oncology research efforts, Dr. Kwok Wong, who's a division director for hematology and medical oncology and a leading researcher in lung cancer biology, Dr. Abe Shishua, who is a thoracic medical oncologist and director of our lung cancer center, Dr. Surfolio, Robert Surfolio, who is our chief of thoracic surgery and director of hospital operations for NYU Langone Medical Center, Dr. Ben Cooper, who is a thoracic radiation oncologist based in Manhattan, Dr. Bill Moore, who's head of the section of thoracic imaging for our Department of Radiology, and Dr. Vamsi Valshetty, who's a thoracic medical oncologist and leads our disease management group in lung cancer in the Perlmutter Cancer Center. Next slide. Let's step back for a second and talk about the burden of lung cancer. Next slide. So many of you may be aware that lung cancer is unfortunately, a very highly prevalent cancer. In the statistics in the bar graph on the left-hand side, you can see that lung cancer is second, it's actually third behind breast cancer and prostate cancer in terms of the incidence of all cancers in the United States from 2013 to 2017. But it's important to note that by far, lung cancer is the #1 cause of cancer-related deaths in the United States among both men and women, and causes as many cancer deaths, if not more cancer deaths, than the next two types of cancer, breast and prostate combined. So lung cancer is a very important public health problem. In 2021, we're estimated to have about 235,000 new cases of lung cancer this calendar year, and approximately 132,000 deaths from lung cancer this year. Next slide. In terms of the incidence of lung cancer in New York State, we are right in the middle of the average at about 58.7 per 100,000. Sorry, 59.1 per 100,000 for New York, which is about comparable to the average for the nation. So we're right smack in the middle. Next slide. And in terms of racial and ethnic disparities, it should be noted that in New York, we have a slightly lower incidence of lung cancer in certain populations, minority populations, compared to Caucasian populations, but that it's still very important clinically in all of these populations, especially as we talk about the stages and treatments, stages at which the cancer is diagnosed and the treatments that are available for individuals. Next slide. In terms of where we rank in terms of survival of lung cancer, and Dr. Mercado has just joined us. Hopefully he'll be able to join us to make comments. If not, he can send me comments that I can read out loud for him. New York State actually ranks much higher than the nation in terms of survival rate of lung cancer. We're doing fairly well, certainly compared to other states around the nation. Now, it should be noted that a 25.7 5-year survival rate, is still not very great, and that the best states are only slightly better than that. So we need to do far better in terms of improving overall survival from lung cancer, which has improved slightly, but not dramatically, since President Nixon declared the war on cancer 50 years ago. Next slide.
Dr. Sterman, it's Rachel. I'm sorry to interrupt you. I see Dr. Mercado is logged on under the attendees. Megan, would you be able to just click on his name and switch him over to panelists?
Well, I'm going to try.
Okay. If you go to the attendees and scroll down to his name, you should be able to right click and it should say make panelist.
Okay.
Let me know when Dr. Mercado is up and running.
Okay, Dr. Mercado, it looks like you're under panelist now. Can you hear us and can you speak to us?
Yes, hello.
Yes, great, welcome.
Excellent.
Thank you.
So Dr. Mercado, welcome as a panelist. And what I'm gonna ask you to do is since we've not divided up the slides, I'm gonna briefly, as we go through the slides, make some comments, and then I'm gonna ask you for any additional comments that
Sure.
are relevant, especially focused on your Brooklyn population that you're primarily responsible for.
Absolutely.
So my comment here was about the fact that we have much work to do in terms of improving survival in lung cancer, even though New York is fairly good compared to the rest of the nation. But that 25.7% 5-year survival rate is not nearly good enough to where we want to be. Next slide. So this is very important, and I'd like Dr. Mercado to comment, but I want you to look at the disparity between these two bar graphs. The top bar graph talks about, shows us the stage at diagnosis, with the bluish gray bar of 23% representing those patients currently who are diagnosed with lung cancer at an early stage, 23%. Which means that the remainder, 77%, are either unstaged or diagnosed at an advanced stage. And this is really important. And this is where lung cancer screening is going to, we believe, have a huge impact. Because when you look at 5-year survival, and remember that 5-year survival in oncology is essentially a surrogate for cure. If you've survived 5 years from a cancer with no evidence of recurrence, at least in lung cancer, you're considered cured from that specific cancer most of the time, especially with early stage disease. But you can see that if you have advanced disease, the pink or the yellow, that your 5-year survival goes down significantly. And if you have distant metastases present with disease outside of the chest, for example, your chances at 5-year survival, even in 2021, are 6%. So that's very low. Dr. Mercado, any thoughts and comments?
Yeah. No, absolutely. This, I think, well, I joined, first of all, at the right time, because this, to me, is the most important slide of the whole presentation. Because many of the patients that come, and when we see Dr. Sterman or myself, they expect that this has some sort of, they have to have some symptoms for them to get a CAT scan, or they have to have any type of red herrings or red flags to alert them. When you're talking about breast cancer screening, you're thinking, you know, it's encouraged for women to kind of like look for nodules. When you're talking about colon cancer, you're thinking about, you know, any signs of blood in the stool, things like that. We do not have that in lung cancer screening, and that's why it's important for the program in lung cancer screening to happen, because I do not want to diagnose somebody with a stage 3 or 4 lung cancer. We want to make sure that we diagnose these cancers very early, because the difference, as you see in this slide, as Dr. Sterman pointed very well, it's staggering. The diagnosis and prognosis of these patients, when diagnosed early, make a huge difference. So it's important for us, and especially with the new guidelines that we're going to discuss later, to really stress out in the community about the importance of doing a lung cancer screening now that we have. You know, Dr. Sterman and I have been doing this for a while, and we've been waiting for a long time for lung cancer screening guidelines to happen. You know, in the 80s and the 90s, CAT scans were not good enough, and there was not enough evidence to support a lung cancer screening, and now we have it. So it's our role as providers to inform the population that this is something that is going to have a huge impact on their health.
Thank you, Dr. Mercado. And just what I would say, this is a very important take-home slide, perhaps one of the most important. And if you think about it very simply, how can we improve 5-year survival? How can we improve cure rates in lung cancer? We make more of the yellow and pink into blue. That's called stage shifting. If we can diagnose at an earlier stage, then we'll dramatically increase the percent of people who will survive 5 years. It's that simple. It sounds so simple, but we hope that that's the case. And lung cancer screening, we believe, will allow us to stage shift and improve that survival accordingly. Next slide. So this just shows you, again, the racial and ethnic disparities in early diagnosis. And what's interesting is that there are differences here in the different populations in terms of who's diagnosed at an early stage. And I would say patients who are identified as Black Americans and Latinos are less likely to be diagnosed at an earlier stage, and I would include Indigenous Americans as well in this, than certainly in New York State, than Caucasians or Asian American or Pacific Islanders. But again, if you look at the overall rates, as we just saw in the bar graphs, if the best rate of diagnosing at an early stage is 27%, we can do better across the board in all populations. Dr. Mercado?
No, absolutely. And one of the things that has curtailed not only the staging, and we can discuss this later, is that one of the things that was not allowing us is that many times we really didn't know what to do once we found these nodules and this lung cancer screening. So that created an aura of uncertainty among providers, especially here in Brooklyn. That has all changed, and we'll discuss it later on. But this is, when I see this slide, to me, it's such an important slide to, we have so much room to improve. We have a significant room for improvement. So as Dr. Sterman was mentioning, is that we have a huge population, very diverse population here in Brooklyn, specifically of all the boroughs. And I believe that, again, is really fruit ripe for the taking. We have to start. Dr. Chacho and I were discussing this yesterday, and he was saying, "Oh my God, all these nodules are popping up." It's like, well, yes, they are. They're out there. We just need to find them.
Next slide, please. So let's talk about lung cancer screening, because I think this is the key to us identifying people at an earlier stage and to improving survival. Next slide. So lung cancer screening, the concept has been around, as Dr. Mercado alluded to, for quite some time. But it really didn't take hold in the United States until the publication about 10 years ago of this landmark clinical study called the National Lung Screening Trial, or NLST. Patients who were included in this study, which was run by the National Cancer Institute across multiple hospitals across the United States, took high-risk patients, and these were identified as patients between the ages of 55 and 74. They were current or prior heavy smokers of at least 30 pack years, meaning that they had smoked the equivalent of a pack of cigarettes a day for 30 years. And they were either active smokers or they were former smokers who had quit in the last 15 years before entering the study. And these high-risk patients were randomized to one of two interventions, either a yearly chest x-ray for 3 total chest x-rays, or a yearly low-dose chest CT scan without intravenous contrast, a very simple, very fast, low-dose scan, each year for a total of 3 years. And when they looked at the outcomes, it was really dramatic, with a relative reduction in lung cancer-related mortality with the low-dose CT scan group of 20% compared to the chest x-ray group. Just to compare, the relative reduction in breast cancer-related mortality with mammography is about 5%. So I'm not saying mammography is not important, it's very important, but it just tells you how impactful lung cancer screening with low-dose CT scans is and can be. Dr. Mercado, any comments?
No, I mean, this was a landmark study when it was published. And as Dr. Sterman alluded to, there had been some, especially in Japan, there had been some studies that were leaning towards the efficacy of CAT scan as a good technique to screening. But there were worries at that time about, the amount of radiation that the patients will have to go. What were the intervals that these patients will have to? So this was a great first, a great starting point to start, justifying screening, and that really kind of like steamrolled the movement towards screening patients towards, again, discovering the early stages of what to do with them.
Next slide, please. So back 10 years ago, the United States Preventive Services Task Force made a recommendation that lung cancer screening should be approved. And this was ultimately approved both by the Center for Medicare and Medicaid Services, as well as by most private insurers. So over the last decade, we have had lung cancer screening approved. And as we'll show you, unfortunately, the numbers of patients who actually were screened compared to those who were eligible was very low. Most recently, in March of this year, as I said, right hot off the press, the same United States Preventive Services Task Force has made a recommendation for a modification of the guidelines. The guidelines before were based upon the National Lung Screening Trial entry criteria. So screening started at age 55 and went to either age 74 or 77, depending upon which guidelines an institution was following. But in March 2021, the US PSTF recommended that the age of screening be decreased to age 50 from age 55. They also recommended that the amount of smoking that qualified you to be a high-risk patient decreased from 30 pack years to 20 pack years, the equivalent of 1 pack a day of cigarettes for 20 years. And the other aspects remained the same, that you had to be either an active smoker or a former smoker quit within the last 15 years, and you couldn't have had a documented case of lung cancer within the past 5 years. Why are these guideline recommendations so important? They're so important because we know that underserved populations, minority populations, have a higher rate of lung cancer at a younger age and at lower amounts of cigarette smoking. So for example, the African American population has a higher rate of lung cancer at a younger age and at less pack years than Caucasian population. So there was a disparity based upon the prior guidelines, and we are trying to be able to provide lung cancer screening to be able to save lives more broadly across the entire population and decrease these disparities. Currently, CMS, Centers for Medicare and Medicaid Services, is holding a public comment period through today, but we anticipate that a national coverage determination will be by spring of next year in terms of these expanded guidelines. Dr. Mercado?
No, absolutely. One of the biggest changes that this brings is one that pulmonologists like me and Dr. Sterman have been, really asking, is because the previous guidelines, again, great starting point, but it did not fit with our clinical criteria and what we were doing really in the field, and that created again a disparity between what we could have been doing and we were told what to do. Now, remember that these are guidelines. In the everyday, if you were suspicious that somebody, needed a CAT scan, if I saw somebody that needed a CAT scan, we can tackle with that. But again, it was necessary, I believe, that to really update the guidelines to reflect better what the everyday daily practice of both advanced bronchoscopies and everyday pulmonologists who were seeing. And these guidelines that were updated clearly are a great example of how to adjust to the population that we see. And so this really, because for example, just as an example, we used 20 pack years as a diagnosis of COPD, probable and along with the chronic obstructive pulmonary disease diagnosis. So really, these guidelines really now are way more practical, and it really embraces the everyday practice of pulmonary medicine much, much better.
I would just add, thank you, Dr. Mercado. I would just add that the estimated increase in the number of individuals eligible for lung cancer screening on the basis of these updated guidelines is an 83% increase in the number of people. So just to remember, as we'll look at data going forward, we've not been very good on the previous guidelines of getting people screened who need to be screened or should be screened. So we have an even greater imperative, which is one of the reasons why we're talking today about getting this larger population screened, because this is the way we're going to save lives. Next slide. So what are the benefits of lung cancer screening? At the risk of repeating myself, these are really important points to be able to hammer home. Number one, lung cancer screening finds 80% of lung cancers at an early stage when it is more curable, going back to that stage shifting that we talked about. If we don't screen, 70% of lung cancers, going back to that bar graph, will be found at a later stage when it is extremely difficult, even with the newest treatments and the newest diagnostic techniques. It's little chance for a cure for these advanced stage cancers. So we want to diagnose patients at an early stage. And then I would also add that, as you see in the third bullet, that the scan allows you to look at other parts of the body, not just the lungs, that you may find things that could be medically concerning and may need follow-up. Incidental findings. So we commonly find thyroid nodules. We find lesions in the adrenal glands. One of the important things that we're actually looking at together with our cardiology colleagues are the calcifications in the coronary arteries that may be an early detection of coronary artery disease. And can we screen for both coronary artery disease and lung cancer at the same time and save lives from heart disease as well as from lung cancer? So very, very many benefits of lung cancer screening. Dr. Mercado, anything else?
No, I think that that's perfect.
Next slide, please. So what can you expect during lung cancer screening? So once a patient is referred, our program staff will reach out to discuss the benefits and risks of screening. Long Island patients will discuss this with the referring providers. A coordinator will call to verify eligibility and to schedule a patient for a low-dose CT scan. Again, for those of you who are not aware, and again, my apologies to those of you who may know this even better than I, for a CT scan, patients lie on a table that slides through a donut-like scanner. It's not like an MRI, so it's open-ended at both ends, so people are not, if they're claustrophobic, there's no need to worry. They're asked to keep very still and hold their breath for the 20-second duration of the scan itself. The entire exam, again, there's no puncture, there's no injection. The entire exam takes less than 5 minutes. So it's incredibly quick. After patients complete the low-dose CT scan, the program staff will follow up with patients and the referring providers to discuss results and next steps. Anything to add, Dr. Mercado?
No, and this is a question that I get asked all the time, because patients do, sometimes are worried about, the length of the scan, if they're going to be. So this illustrates how simple of a diagnostic test this is. And the other thing is on the name of the scan, it's a low dose. So what that low dose means is that it's a very low dose radiation. So the amount of radiation that this has is not even compared to other type of radiation techniques that we use. So we are using less radiation than other diagnostic imaging studies. So that's also another reassuring information for the patients when they ask.
I tell patients that it's about the same radiation as 4 chest x-rays, or about the amount of radiation that you would get if you flew from New York to Los Angeles. So, and some people do that every week. Next slide. So what's really important, and I can't stress this enough, is that lung cancer screening is the first cancer screening test, actually the first screening test that I'm aware of, in which there is shared decision-making, which means that prior to ordering a scan, a medical professional, it could be a physician or a nurse practitioner, needs to have a discussion with the patient of the risks and benefits of screening itself, as well as the importance of reducing tobacco use and providing smoking cessation services. And these harms of the scan are really important to go over, because no medical test is benign. And again, this is not an invasive test. There aren't immediate risks of the test itself, but when we do a scan, there are false positive results. We may find lesions or abnormalities in the lungs or elsewhere that may not be cancer. In fact, the majority of spots, nodules that are found in the lungs on lung cancer screening are not cancerous. So it's important to recognize that up front. Secondly, that in following up some of these lesions, we may do invasive procedures. You may be referred to Dr. Mercado for a special kind of bronchoscopy called robotic bronchoscopy to biopsy one of these lesions, or to a radiologist for a needle biopsy, or to a surgeon for removal of one of these nodules, each of which has morbidity to it and could have complications. As I mentioned, there are incidental findings in the other organs of the body that may not have needed to be found. You might have a benign growth in the thyroid that is never going to bother the patient, but it's found on the scan and it needs to be followed up. You may have what's called overdiagnosis, which means that you may have a very, very slow growing lung cancer that may not have impacted upon a patient, especially as we get to the upper age range. Let's say a 79-year-old who comes for lung cancer screening, and you find an early stage indolent lung cancer that may not have impacted upon their survival, that may be so-called overdiagnosis. This may be a lung cancer that we didn't need to diagnose. There's the radiation exposure that we've discussed. And although Dr. Mercado emphasized that the scan itself is low dose, if you're 50 years old and you started lung cancer screening, you will be getting a lung cancer screening scan for 30 years from your age 50 to age 80. And so there is a cumulative risk of radiation exposure, even from these low dose CT scans, although that risk is small. And then there's the cost. Now, most of the time, if you meet the criteria for lung cancer screening as set by CMS and set by private insurers, the cost of the scan is paid for by insurance. But if you are outside the guidelines, that cost could be a problem, or if you are uninsured. It is very important that this discussion take place prior to ordering the scan, and that that shared decision-making visit and discussion be documented clearly in the medical record. Dr. Mercado, any thoughts or comments?
I think that these are very important considerations, especially the one that if you start at age 50, you're going to have, you know, the scans, you know, on a frequent occasions, and specifically since we, like Dr. Sterman mentioned, you know, it is very important that these scans are reviewed. And in fact, we started here in NYU a nodule board to review all nodules, because again, not every nodule is suspicious, not every nodule is meant to be biopsied, not every nodule needs to be significantly followed up. So it requires an examination, requires a discussion about what to do with these nodules, because they're going to pop up, and that not necessarily mean they're a malignancy. There's significant amount of conditions that can cause lung nodules to appear in the lungs. So it is important to be reviewed. And that's part of the whole concept of a lung cancer screening program for specialists to go. Now, once you find them, then it's also a different discussion on what to do with them and whether to obtain either biopsy or continue with follow-up. So yes, very important to discuss with the patient about the potential implications on lung cancer screening in their lives.
Next slide, please. So this is, I'm not going to go into great detail, but just to say that we have a decision tree, something called LungRads is what we use. It is probably the most commonly used algorithm for following these nodules. And based upon the size of the nodule and whether the nodule is new or growing, they can be either a LungRad 0, 1, 2, 3, 4A, 4B. And we have varying recommendations based upon the LungRad score of the individual nodules that are identified. And these can range from a follow-up low-dose CT scan in 12 months to even tissue sampling or even resection of a nodule based upon its appearance. And so the guidelines on which we have a group discussion as part of our nodule board, and in terms of the recommendations that go back to the referring providers, are based upon this LungRads decision tree. Next slide. Now, this is what I referred to before, which is, these are with the current guidelines, the age 55 to 74 to 77, 30 pack years. In New York, we are right at where the nation is in terms of our average percent of the population who meet the high-risk criteria. This is not the overall population. This is the high-risk population. In New York State, we are at 5.7%. That is not good. We need to do far better. If we are going to shift the stage to save lives, detect lung cancer at an earlier stage, we need to do much better. And if you look at the top tier, the far left of the bar graph, the best state in the United States is still less than 20% in terms of the high-risk patients being screened. And then we're going to be increasing, we hope, our age range from 50 to 80 and decreasing our threshold for smoking from 30 pack years to 20, as I mentioned. And so we're going to have an even larger population that should be screened, and we need to improve our percentage. Dr. Mercado, any thoughts or comments?
No, basically that this graphic shows you that And not only as a state, but as a country, we need significant better communication with the community, with the population, and let them know that this is available for them, and this can, you know, save lives, as Dr. Sterman is saying. So we definitely need to get these numbers up.
Next slide, please. So I'll tell you a little bit about the NYU Langone Health Lung Cancer Screening Program. Next slide. So in terms of the history of the program, our program began in Long Island before our hospital in Long Island in Mineola was actually part of NYU. This was built as a referral network of local primary care physicians, pulmonologists, cardiologists, and gynecologists who referred into our central location now at NYU Langone Hospital in Long Island in Mineola to arrange to have low-dose CT scans performed on the basis of the NLST guidelines, have the lung RADS readings identified, and then those results forwarded back to the physicians who had referred the patients. In 2016, after I came to NYU from the Hospital of the University of Pennsylvania in Philadelphia, we initiated the program in Manhattan. And this was a referral network of electronic medical record, or EPIC users, and patient self-referral. This was based upon what's called a best practice alert, which is that if you're using an electronic medical record and the patient meets a criteria for lung cancer screening based upon NLST guidelines and CMS approval, they would get an alert on the EMR, and you could click a button and refer your patient directly to the lung cancer screening program, or patients could self-refer. And then in 2020, last year, we were very proud to initiate our lung cancer screening program in Brooklyn, and in 2021 in Queens. And again, this uses the system of the best practice alert through the EPIC EMR, as well as patient self-referral. And these programs come under the supervision of Dr. Mercado and Jose Lara. Next slide. So what are the benefits of the lung cancer screening program at NYU? We have dedicated nurse practitioners in Brooklyn, and we just hired a fantastic new lung cancer screening program nurse practitioner from Manhattan, who will conduct the shared decision-making with patients. The patients will be actively monitored by program staff, both administrative staff and medical professionals. The patients who are current smokers are offered or referred for tobacco cessation counseling. Their CT scans will be reviewed by a team of experts if a lung RADS 3 or 4 nodule is identified on the basis of the radiology read. And the referring provider is included in each step along the way. Dr. Mercado?
Yes, that's correct. And basically, this is what I was referring to before as to, you know, this is a great example of, as you see in this nodule, in the example here, it's one of the reviews and discussions that we had in what is the best way to handle this nodule. And again, we have specific protocols and guidance that all the experts, we have all the participants that actually are going to do the procedure itself, whether it is to do it through interventional radiology or interventional pulmonology or surgery, to see what is the best step for the patient to take from here.
Thanks, Dr. Mercado. Next slide. And so this is actually one of the rate limiting steps that you would think would be almost a no-brainer, but is really important. And this is actually where the medical assistant plays a very important role, because he or she who is taking some of the information from the patient, including the smoking history, is extremely valuable, because in order to trigger a best practice alert through our electronic medical record that someone should be referred for lung cancer screening or considered for lung cancer screening, we need to take an accurate medical history. And an active smoking history, tobacco history, is not sufficient to just say the patient smoked or quit smoking. We need to know the quit date. We need to know the type of tobacco, cigarettes, pipes, cigars. We need to know with good accuracy the packs per day and the approximate years of that packs per day. We also need to know, not necessarily for lung cancer screening, but it's important for other purposes, whether they're using smokeless tobacco, specifically electronic cigarettes. And that's for a lot of other health effects that smokeless tobacco can have, including, for example, snuff and chew, which can lead to oral cancer, cancer of the mouth, the tongue, the head and neck. And also to document whether smoking cessation, tobacco cessation counseling has been given. So we really need to redouble our efforts to educate all of our staff in our outpatient practices to understand the importance of marking down, taking a very good tobacco use history and documenting it successfully. Dr. Mercado?
No, that's correct. And just to add, there's also under social history, there's a below that was added for electronic cigarettes and Dr. Sterman. So there's also another screen added into EPIC that also points out, because electronic cigarettes, as we know, had been known to cause damage to the lungs as well with the E-valley, but also can cause lung nodules to appear. So it's important to note that as well in the chart.
Next slide, please. So the appropriate tobacco use history will then cause a best practice alert, which will alert the provider to the potential eligibility that their patient may qualify for lung cancer screening based upon the criteria that you see here. Now, we have recently adjusted our best practice alert, as you can see, for the new recommendations by the United States Preventive Services Task Force, with age range between 50 and 80 and a threshold of 20 or more pack years. Again, please understand that this, not all payers necessarily yet will approve the lower age range and the lower smoking threshold, but this is the recommendation, and this will get patients and providers thinking about lung cancer screening for their patients. Next slide. And so if you get this alert, you will, and you're interested in doing this, you can open the order set and you can accept lung cancer screening. And then you can also have documented that the patient has declined. If you've discussed this with the patient and they're not interested in lung cancer screening, we certainly would like to know, or you can say that they're not eligible. So the alert may have come up, but something else may not have been documented in their medical record. So for example, they may have had a lung cancer 2 years ago that was treated, and the alert pops up and the medical record doesn't recognize that they had a recent lung cancer. Or they may have quit 16 years ago and somehow that did not really come up on the initial record, and they're not eligible. So I think that this best practice alert gives some leeway for the provider to decide whether the provider, he or she, would like to refer the patient on. We encourage all providers to have this discussion with the patient and to review the criteria for lung cancer screening. Next slide. So this is the workflow. And again, this is somewhat of a reiteration, but the referral site screens the patient for tobacco use and lung cancer screening eligibility. The referral site then places the ambulatory referral to the lung cancer screening program or directly refers to the lung cancer screening program staff. The staff will then verify eligibility. They'll conduct the shared decision-making at some sites. And again, this will be done ideally through our nurse practitioners. We will facilitate the prior authorization and schedule the scan, and we'll offer tobacco cessation counseling or provide links or access to tobacco cessation counseling. The lung cancer screening program staff will also review the results, provide follow-up with the patients and referring providers, will assist referring providers in connecting to the appropriate specialists like Dr. Mercado in Brooklyn, for example, and will monitor the ongoing care of patients to ensure that it's meeting guidelines and is the best care for the patient. The majority of lung cancer screening patients will only need to return for an annual follow-up low-dose CT scan, because the majority of the scans will be lung RAD 0, 1, or 2, and not 3 or 4. Most insurance companies will cover the cost of the test. However, some insurance plans will require co-payments and we advise patients to check their individual coverage. Any comments, Dr. Mercado?
No, that's perfect.
All right, next slide. So one important new aspect of the NYU Langone Health lung cancer screening program across the entire health system, Brooklyn, Queens, Manhattan, and Long Island, is the recent establishment of a lung nodule review board. This actually is part of the initial recommendations by the USPTSF of how lung cancer screening should be implemented at a major medical center. And so what this means is that we have established a multidisciplinary team consisting of interventional pulmonology, thoracic oncology, thoracic surgery, and radiology that is available to review all of the lung RADS 3 and 4 scans, the nodules that are seen on these scans, identified through the NYU lung cancer screening program. And we will review and come up with a recommendation, a consensus recommendation that will either agree with the current referring providers and radiologists, or if there's a discordance, we will go back to the referring physician and to the patient if needed, and recommend potentially a more aggressive follow-up of a nodule that the review board considers concerning. Next slide. So what is the project impact? As we're looking for the numbers of patients who are enrolled actively in the program, you can see that there has been dramatic growth of both new patients as well as follow-up patients in both Manhattan and Long Island. We currently follow over 450 patients in Manhattan and over 600 patients on Long Island. And again, these are a small percentage of the patients who overall qualify for lung cancer screening. We know that the detection rates of lung cancer are, I'm sorry, there's a question about Brooklyn. We just started the Brooklyn program, and so we have not in 2020, so we don't have the rates for Brooklyn, but we hope to have them over the course of the next several years. The detection rates are low. Remember that most of the nodules that are identified are not lung cancer. So we need to be able to capture large numbers of patients in the lung cancer screening program to increase the detection rates of lung cancer and all cancers and improve survival. Next slide. So who are our partners? We have several practices in each location that are partners. In Brooklyn, we partner with the Family Health Centers of NYU Langone, with the Levitt Medical Practice, with Ambulatory Care Rego Park, which is actually in Queens, and Ambulatory Care Bay Ridge. In Manhattan, we partner with a historical group, which was the NYU biomarker study, which preceded the implementation of lung cancer screening. Our own internal medicine associates, the Center for Men's Health, the Center for Women's Health, Ambulatory Care West Side, the Murray Hill Medical Group, and Concord Medical Group. In Long Island, we partner with the Huntington Medical Group, which is part of NYU, as well as a large network of providers in Long Island who are outside of the NYU Langone Health system, but refer their patients in to our Long Island hub for lung cancer screening. Next slide. So how can you join the program? If you feel your practice would benefit from the NYU lung cancer screening program, we recommend that you contact Rachel Nelson, and Rachel's email is listed here. All of our emails are pretty simple. We have the same suffix at nyulangone.org. So I'm Daniel.Sterman at nyulangone.org. You can also reach out to me, but Rachel should be your primary contact. And obviously, if you use Epic, there's the ability in our health system to have an ambulatory referral to lung cancer screening through having a direct referral or best practice alert. Patients can also self-refer by calling to one of the numbers below. Here are the numbers listed for Brooklyn and Queens, Long Island, and Manhattan to access our lung cancer screening program. Next slide. So again, this is my contact information. Dr. Mercado had to go to do a procedure. His email and my email are here. We are available 7 days a week for any questions regarding lung cancer screening or how best to access our lung cancer center and our multidisciplinary programs across our health network. Next slide. So we have some time now for any questions. We have about 7 minutes remaining. So if there are any questions from the audience, I think they can be put into the chat function. I did think I answered the question about the numbers from Brooklyn, and we just started the program less than 1 year ago now. So we are collecting the data, and we'll be providing data about the impact of our Brooklyn program over the course of the next year or so. Are there any additional questions?
Dr. Sterman, it's Rachel again. I just wanted to thank you and Dr. Mercado so much for a great presentation that was very informative, and it's very exciting to see all the great work that's being done. And I'd also like to thank Megan Hasseltine and Rachel Nelson for helping organize the program. And before we wrap up, last call for questions. If you have any questions, you can put it in the Q&A box.
You can also email me your questions directly at daniel.sterman@nyulangone.org or Rachel Nelson at rachel.nelson@nyulangone.org.
Okay, I don't see any questions coming through, so that is all for today. And thank you so much for participating, and thank you to everyone who attended today.
Thanks
Enjoy
so much.
the rest
Have a
of your
great day.
We'll see you next time. Thank you. Bye.